Like I said, I run our Women's Heart Health program here at Stanford, and our program involves several people. So myself, and then my nurse practitioner, Mary Najedli, Sandra Sai, who's going to speak today, does preventive cardiology. Dr. Edwards, who is our psychologist in the Women's Heart Health program. Dr. Kandawal, a non-invasive cardiologist. Both of those two are on maternity leave. That's one of the disadvantages of running a Women's Heart Health program, is that people get pregnant, but that's okay. And Dr. Park, electrophysiologist, and then Dr. Chandra, who's going to speak to you today. So I wanted to review with you the risk factors for heart disease, and I know it's an overall educated group, so you all probably know the risk factors, but just to make sure we're on the same page. So there are some risk factors that we can't modify, and then there are some that we can. So a couple that we can't modify is our age. And so once you get over 55 years as a woman or 45 years as a man, your risk of heart disease is considered to go up, and it continues to go up. Unfortunately, we haven't found a pill for that one. Family history, the same thing. And when we ask people about their family history, we're really interested in first-degree relatives. So it's not necessarily your cousin's brother or sister, but it's actually your father or your brother on the male side, or your mother or sister. And having heart disease actually at quite a young age. So, you know, if your father had a heart attack at 85, you know, that's unfortunate, but doesn't necessarily increase your risk, just because his risk was increased by getting older. And then there are several things that we can modify. So cholesterol is one thing we look at, and we tend to focus on LDL, which is bad cholesterol. And the numbers kind of keep changing in terms of where we want to. But certainly the higher this is, the more your risk goes up. And then we also look at good cholesterol, and we want that as high as possible. And as that goes down, your risk goes up. The cutoff that we have for women is we like them at least above 50, and ideally above 60. For men, above 40, preferably. Diabetes increases your risk of heart disease, and in women, your risk is actually increased just by having an impaired fasting glucose, so sugar that's above normal but not quite to the diabetic range. Having high blood pressure increases your risk, smoking, having a sedentary lifestyle, and then being overweight or obese. So the American Heart Association has talked about several things that will increase one's cardiovascular health, and they've put out this simple 7 idea, and these are things that we're all trying to encourage people to do. So get active, eat better, lose weight, stop smoking, control your cholesterol, manage your blood pressure, and reduce your blood sugar. So you can see those address each of the risk factors that we know about. And as people have more risk factors, their risk obviously increases. So on the American Heart Association's website, you can actually go and you can see how you score on all of these and figure out kind of what your heart score is. If we look at where the US is, you'll find out they're actually not too good. And so if you go on that website and do your score, you may find that you're not as good as you were hoping, but you're not alone in the US. So they've looked actually at how many people are actually kind of reaching the ideal levels of health in these different areas. And what we found, and particularly among diet, people aren't doing very well. So it turns out that almost 94% of US adults have at least one of these metrics at a poor level. And 38% have at least 3 of them at a poor level, and only 12% have 5 at an ideal level. And less than 1% actually will meet all 7 of these metrics at an ideal level. So overall, as a country, we're not doing that well, but these are all things we're trying to work on. And so one of the questions is, how can we improve that? Things have been getting actually worse and not better. There hasn't been any decrease in terms of the overweight or obesity epidemic since 1980. And you've heard these statistics over and over, but 68% of adults are overweight and 35% are obese. And we know that this has gone into children and adolescents as well. And so the numbers are quite startling. You know, and this is creating then a whole generation of people that are going to have even more heart disease than we're seeing now, which, as you guys know, is the #1 killer of women and men in the United States. And then in terms of physical activity, that's also gone up. And so this is becoming more inactive. So men, 11% to now 43% of men are considered inactive. And women, over half of women now are considered inactive in the United States. So something is wrong, something keeps getting in our way. You know, we get confused along the way. We're not quite sure how to get enough exercise. There's a lot of conveniences in society that makes it tough for us. And one of the questions, I think, is technology something that is a problem, or is it a solution? And I think the answer is probably somewhere in between, and that it ultimately depends on how we use it, and that we may be able to harness it to do great things, but it also has made it so maybe we don't have to do as much as we used to in the past. So if we look at apps and mobile devices, there's actually a lot of behavioral principles that come up and are playing a role when we're using these things. So one is just goal setting, and we know that goal setting is something that's going to make it more likely for you to achieve what you're trying to do. And so when you use these apps or devices, you have to come up with, well, what do I actually want to accomplish? It also helps you monitor your activity, and oftentimes things that are hard to monitor. So you couldn't count all your steps every day, but a device can do that for you very easily. Or maybe you aren't always quite accurate if you're keeping track of your diet, you know, but this could maybe do it for you without having to work so hard. And writing stuff down can be difficult, and this way it can be kind of gathered real time. And then what these apps will also do is kind of give you real objective data about what do I have in terms of the discrepancy between my current behavior and my goal. So you can actually see that, and that's also helpful for people who are trying to institute behavioral change. It also helps you with action planning to achieve your goals. So you'll set out, okay, what do I need to do? How am I getting closer to that goal? And then there's a lot of self-monitoring, there's feedback, and there's support. And we know that these are also important. So we need this feedback to know, okay, I'm not quite there, or this didn't work, so I can correct it. And just tracking things, it turns out, will change people's behavior. So there's something about just an awareness that you might not have otherwise. You know, if I ask people in clinic about their diet, they're usually like, oh, it's pretty good, and they, you know, kind of can say, but if people actually track it, we may see something very much different. And that we kind of remember the good things, like, oh, I had a salad yesterday, and we forget that, you know, we hadn't had a salad in 2 weeks prior to that. And then having some kind of reward, and sometimes the reward can be something just as good as somebody saying good job, and having a pal with you somehow with your mobile device, and that can really help as well. So this is kind of the whole cycle then to hopefully getting some behavioral change. So setting this realistic goal, evaluating your ongoing behavior against that, getting the feedback so that you can actually then change things and hopefully change this discrepancy that you see, and then continuing to self-monitor and come up with how do I overcome these barriers, and then giving yourself some sort of reward. And with this, of course, we have to always remember, you know, chocolate cake probably isn't going to be the best reward, or you know, things like that. So, and there are other kinds of rewards. So again, I think social reinforcement is a nice reward, or saying I'm going to go to the spa or something like that, but hopefully picking healthy rewards as they come along. So these are the top 5 predictors of behavioral change, and I've kind of gone over these. So goal setting, modeling, so seeing somebody else doing what you're thinking about doing, having some sort of reward, and it seems that a positive reward is probably better than a negative type of reward, where you're like, oh, that was terrible, you know, that doesn't necessarily get you motivated to do it again. And then some sort of social support, and we're actually going to talk about this even more with a study that we're doing here at Stanford. And then having good self-regulatory skills, and this is really the ability to overcome kind of impulses or desires that you might have, you know, that would get in the way of you actually accomplishing your goal. So there's been some studies looking at this. Most of them are on the small side, but they tend to show that if we use these mobile devices, that we will see some sort of success. So this is just a study with weight loss using a mobile phone. 125 patients, they did text messaging versus no sort of intervention, and those who were in the text messaging group had a significant reduction in their weight loss as well as their waist circumference versus those who weren't. Similarly, here's a study where they looked at diet and physical activity, 100 to almost 200 patients, and they had a group therapy arm versus wearing an armband that was giving you some feedback on your physical activity versus having both. and they found that the armband group plus the group therapy was important. And so this shows that maybe sometimes it's not going to just be the data, but again, that some sort of social integration is going to be important to being successful. So there's lots of apps out there and lots of devices. So how many people in the room use apps or devices right now for health? Okay, so maybe third, something like that. So that's pretty good. So Lose It's a popular one. I think it was like #1 on the health apps or something. I don't know. There was something looked at that. And so people like this, and it's quite good and gives you a lot of feedback. So, and I just kind of show these as possibilities. There's a ton out there, but Lose It is one, and it helps you with diet as well as physical activity. MyFitnessPal, I think, was #2. So another very popular one, similar concept of diet and physical activity. And then, another part of health is certainly stress reduction. And so our psychologist, this is one that she recommends, so Breathe to Relax. And this has kind of little exercises that you can do in terms of breathing and muscle relaxation. And it kind of guides you through those if you're feeling particularly stressed. And then my new favorite app has been Headspace. I don't know if you guys have heard this. So this is a Take 10. It's a mindfulness app, and it basically walks you through 10 days of doing 10 minutes of mindfulness, and it kind of gets you going and makes it so it's not so scary to do. And then the thing with these, as you guys know, is that they're very interconnected now, right? So it's not simply an app, but it's the app on your phone, and then the thing on your wrist, and then your scale, and on your computer, and you can put it all together, and you can make charts. And so there's lots of things you can do. Plus, you're connected to social media, and tweeting can be a part of this too, which we're going to talk about. So there's a ton of interconnectivity. It's just really exploded, and making these things really something that we all have easy access to and can take advantage of. So there's a strong potential with mobile health, certainly, and our health is really what happens to us on a daily basis. And so physiology, behaviors, environment, these all affect our cardiovascular health, but most of the things we do, we actually don't end up measuring. And so technology really gives us the ability to track all of that information and on a real-time basis. And so that can be helpful on a personal level, and we think in the scientific world that it may actually be very helpful on a scientific basis too, because a lot of the studies that we do in the past where people simply write down, this is what I ate, or this is how much I walked, and whether or not that data is very accurate is unclear. And so I wanted to also show you, this is My Heart Counts, which was recently released by Stanford. And this is using this technology in a population science study. And anyone can sign up for this, and you get some information back about your own heart health, but you also are contributing your health behaviors into a population study. And one of the hopes is this could be one of the biggest worldwide population studies that's done, where it's collecting all of this data and finding out what are people doing and what sort of effect does that ultimately have. So check out My Heart Counts. So I want to just tell you a little bit about how much exercise you need, and then I'm going to hand it over to Jody to talk to you about some current research we're doing and what has led up to that. So in terms of how much physical activity we recommend, it comes down to having aerobic physical activity as well as anaerobic or resistance training. For the most part, we recommend 30 minutes of moderate intensity physical activity on most, if not all, days of the week. This comes out to about 150 minutes if you look at 30 minutes over 5 days of getting moderate intensity physical activity. Moderate means that you can still talk to somebody, although you may be breathing a little harder, breaking a sweat, but you can still carry on a conversation. Moderate is sufficient. You can also do vigorous, and so that's this part. So if you do vigorous physical activity, then you only need 75 minutes per week for heart health. Vigorous is when you're going fast enough that you can't have a full conversation. So you're like, I had a great day at school today, or whatever it was. So that's more vigorous activity. Along with these, we recommend that people get resistance training on 2 or more days per week. And I guess those of you that were in the last talk about bone health, this would also play a role for that. And then there's kind of a mix of those, but those are kind of the basic guidelines. And you don't actually need vigorous activity for heart health, but if you're a person who already likes to do vigorous activity, this at least gives you some sort of guideline. And so the reason I say that is because we're going to talk a little bit more about physical activity and how we're trying to hopefully increase that in our female patients. So I'm going to turn it over to Jody Prochaska, and she's going to tell you a little bit about some study we're doing here. There's some studies she's already done that led to a study we're doing here.
Great, excellent. So Jennifer and her team and Marilee and I are looking to take an innovation that we've been doing in the area of tobacco control and seeing if we can translate it for physical activity promotion. So I'm going to share the findings that we've been getting in the area of tobacco cessation, and then Marilee will talk about the design and what we're building with the physical activity intervention. And if you'd like to be a part of the initial developmental piece of it, Marilee has cards for you to help us with our message testing to make sure our messages are the best that they can be. So she'll tell you more about that. The work that I've been doing is using Twitter. So people probably know what Twitter is, a social media platform, a micro-blogging platform that's incredibly popular. And we're using just the technology of it to create these peer-to-peer support groups. So it is a private group. You don't have a lot of extraneous, buy this Rolex watch kind of messaging going on. It's a support group of individuals who are going through a common process together. And in this example, they were quitting smoking together. And in the one that we're building, it'll be adopting physical activity together. And this is a collaboration with a partner who's in the School of Business at UC Irvine. So why use social media? Well, it's incredibly popular. It is out there. People are using it. And we want to see, can we use it for health promotion? Can we use it for positive behavior change? It's virtually free to users as long as someone's got a texting plan, or if they use their computer and they've got access to the internet, then it's free for them to use this intervention. It's interactive, so they get feedback. It's not that they're just reading static information, but they're getting interactive support from others in the group. And it's accessible. And when you're doing something like quitting smoking and you've got urges and cravings to smoke in the middle of the night, you can reach out and actually get support from somebody on the other side. Similarly, if it's raining outside and you're feeling frustrated and how are you going to get your physical activity, you can get, again, that support from someone who's there for you. And it can be observed, analyzed, and learned from. So we, as researchers, can observe the process as people are quitting smoking or adopting physical activity. And that's been incredibly informative, rewarding, and seeing how people dialogue around a behavior change issue. Now, there are also going to be negatives. There's always pluses and minuses to a use of a technology. And the potential negatives are you going to be able to engage people? So there's a number of programs that are online. There's these apps that are used. And the modal use of it is one time. And so how do you get people to return to it? How do you reinforce that they're getting something out of it? And so that engagement is a really critical piece. And then what we're building is that we're looking to purely have it be peer-to-peer so that there's no expert moderator. It's individuals working together. And why we want to do that is because we want to see, does social support help with behavior change? There's a question around that in the smoking cessation literature. And then also, if this works, it could be incredibly scalable. Okay? Because you don't have to have all these experts that are online and moderating. It'd be groups of individuals who are motivated and engaging and supporting each other over time. Now, the downside potentially with that is that, well, what is the quality going to be? Is it going to be evidence-based feedback and support that they're giving each other? And so we want to look at, are there ways that we can seed the messaging, kind of feed in and manipulate the messaging in a positive way so that it is evidence-based? So before we developed our Twitter-based intervention, we looked to see, well, what's going on in Twitter already? Are people using it for having a quit smoking group? This was done back in 2010, and we saw over 150 different accounts that had the terms quit smoking or smoking cessation. And then we looked, okay, are people following them? And we found about 155 followers per account, so it's a decent number of decent volume. 82 total tweets per account on average. But 49%, about half of them had 100 or more tweets. That's a good level of activity. But then when we looked to see, all right, well, are these accounts active? Has somebody tweeted in the last month? And a tweet is a 140-character message, just if people aren't familiar with Twitter. And about half of them were inactive. Nobody had been posting to that account. And so there's a potential that this could die off. And so that is another thing. How do you keep people active during the intervention? And then we look to see, well, what's the content in these existing groups? Before we develop our own, what's going on kind of grassroots generatively? And we saw a lot of commercialization. So a lot of people saying, buy this herb or this laser treatment to quit smoking. And then we also saw a lot of tweeting on e-cigarettes, electronic cigarettes, if people have heard about that. And this was back in 2010. So my guesses would be that all of these sites would talk about e-cigarettes now. There were only 8 accounts that were akin to a quit smoking support group, and only 4 of those were active. So if you were an individual going onto Twitter saying, I want to quit smoking and I want some support, good luck finding those 4 active groups out of the 155 that were in existence. So that was another issue. And then we looked to see, well, how evidence-based is the dialogue that's going on. We found 14% of the messages that were being generated in these accounts were evidence-based, so promoting smoking cessation medications that are FDA approved, promoting physical activity to quit smoking, and that kind of thing. So the potential for high quantity, you can get a lot of people engaged online with Twitter, with social media, but is there going to be high quality? Engagement, you can get people who are signing on, but will there be longevity for quitting over the long term? And then low cost, but is there going to be high reward? So our aim was to develop an intervention and then evaluate it in a randomized controlled trial. So it's not just that we were going to develop the program, but then we want to see, does it really work? And when you do a randomized controlled trial, it equates your group so that you don't have pre-existing differences that murks up your findings. So we wanted to see, does this help people quit smoking? We wanted to see what predicts engagement, because we thought that would be key for quitting smoking. And then looking at, does the tweeting affect abstinence, the amount of engagement? So I won't go through all this, but people were smokers. They had to smoke at least 100 cigarettes per day. They were given nicotine patch along with the study, so they needed to smoke at least 5 cigarettes per day. We required that they be social media users, and we defined that as daily Facebook use, because we wanted people to engage. So we wanted them to be in that practice of communicating with a social network out there. They were English speaking, they were adults, they lived in the continental US, and so forth. And I won't go through all this with time, but we screened 614 people. We randomized 160 people. And everybody was sent to the National Cancer Institute's website on how to quit smoking. So they got the basics of what you need to do to quit smoking. And we mailed them patches for 8 weeks. And then half either got this Tweet to Quit group, this social media intervention, or they didn't. And so we really were isolating what's the additive benefit of the social media group for quitting smoking. The group was 36 years of age on average. They ranged from 18 to 59. It was largely female. Diversity in terms of education, half were married, 2/3 were employed, and it was largely Caucasian. And we were not happy with that, and we've since gotten a grant to focus on Latino smokers in the next iteration of the study. They smoked about a pack per day for about 17 years on average, and they were moderately dependent based on this Fagerstorm test of nicotine dependence. As I said, we isolated the Twitter support group to see if it enhanced outcomes over just a static website and the patches alone. And we looked at their quitting at 1 week, 1 month, and 2 months post the quit date. These groups, we formed them as 20-member groups. Okay, and it was so peer-to-peer groups. Everybody would set a quit date close in time to each other within 1 week of the start date. And there was no moderator, as I mentioned. They were encouraged to tweet each other daily for 100 days. That was the life of the group that we were foreseeing. And then we would seed it. We had 2 types of messages. One was a topic of the day, that seeding of a message for the day. So how are you managing withdrawal today? Why do you want to quit now? How's the patch going for you? And the idea was to plant a discussion item for everybody to tweet back and to generate discussion. That happened at night. And then the following morning, we tweeted them to say, hey, thank you for tweeting the group. The group really values hearing from you. Or we missed hearing from you. Please be sure to tweet the group today. And that was it. That's all we did. And that was all automated so that we didn't have to have this labor intensity, and really you could scale it up. This shows you the number of tweets per week over time. Much more tweeting going on early when people are quitting and getting to know each other, and then coming down over the 14 weeks of treatment. The 4 groups, 20 participants each, they averaged 1,100 tweets per group, so over 1,000. 75% of members tweeted, so a quarter of members were passive. They may have been lurking and observing, but they did not tweet. And there was a median of 59 tweets per participant for an average of 7 weeks that they tweeted. And this just shows some of the variability, but generally the group's showing the same pattern. And then, as I mentioned, we did an evening tweet discussion topic and a morning tweet, hey, we didn't hear from you, or great to hear from you. And you can see that those two interventions that we did spike tweeting. But what you also see is that only about a quarter of the tweets were from our messages to them, and actually 75% were people just spontaneously tweeting each other, which we really like to see. That shows some of the variability. And then what happened with their quitting? Well, we found a twofold greater likelihood of quitting smoking if they got the Twitter group, if they got the social support group. 40% quit compared to 20% quit at 60 days follow-up. That's if among those who we were able to reach. And then with smoking, if you lose people, one way to control for that is you just count that they're a smoker. So based on, if we counted people who we lost as smokers, the quit rates were 33% in the tweet to quit group compared to 18% in the control group. We looked to see what predicted quitting and tweeting volume, their engagement predicted whether they quit or not, as well as their gender, and men were more likely to quit than women. And that was true both in the control group and in the treatment group. There wasn't a differential treatment effect. And then we saw what predicted engagement, and it was college education, tweeting on the phone, so having it in real time, not necessarily waiting to come home and be on the computer, tweeting at work, and also posting an image or an icon, so identifying themselves in the group. These are the differences by gender. This is in the tweet to quit group, 55% of men compared to 33% of women. And the grant that we're putting now is to look to see, can we increase the quit rates among women by having a women-only group? So we'll have a co-ed group, a women-only group, and then our comparison condition. So tweet to quit appears to be a feasible, efficacious, and inexpensive intervention for smoking cessation. We saw high engagement, and that was related to abstinence. And then our goals in the future is that we are going to look at a gender-specific group. We've got funding for a Latino project right now that we're underway from the Stanford Cancer Institute. And then we're also going to follow people out longer term than just 2 months follow-up. And this is too little too, and I'm out of time. But generally, we did see also some different topics being discussed among the women and the men, with the men much more focused on nicotine replacement, which has been seen in the literature. Women more focused on emotional supportive aspects. And so we're really curious about the dyadic formation of who's bonding to each other and the things that they're talking about and how that differs by gender. And I'm going to hand this over to Marilee.
Thank you, Jody. So Jody showed some great effectiveness of using Twitter to enhance smoking cessation. So we thought, why not use this portal and this forum to try and use it to increase physical activity. So instead of stopping a behavior, this will be about starting and maintaining a behavior. So we know that there's 2 independent health problems that are separate but related to the risk of chronic disease. One of them is that we're not moving enough, and another is that we're sitting too much. And while they seem related, they're behaviorally and physiologically slightly different. So we would use Twitter as a behavior change platform to inspire more physical activity. And Twitter allows us to use both components that Dr. Tremel also addressed that are effective for behavior change interventions. One is the social support, and here it capitalizes on the online community aspect of it, so it's low cost, high access, and still effective. And then the second is that it allows us to also intervene from an expert point of view based on physical activity and also behavior change interventions. So by seeding in things that were also used in Tweet to Quit, we would be able to seed in ideas that generate discussion, prompt strategy sharing, provide reminders and inspire goal setting, but also use this in a theory-based driven way. So what are we planning on doing with this? We're planning on screening and developing intervention for 75 women in the Women's Heart Clinic at Stanford. And we will look for women that currently do not meet physical activity guidelines. So instead of making the already active more active, we're looking for people that are currently not meeting the guidelines and are interested in increasing their physical activity. And then we'll randomly assign them to one of 3 groups. So the first group is going to be the whole gamut intervention. 25 people are going to get a Fitbit to monitor their behavior, and then they'll get our Tweet for Wellness or Twitter intervention that's based on the Tweet to Quit. But you, as Dr. Tremel pointed out, know that monitoring your behavior will kind of influence it in some way. So we're wanting to tease out the influence of self-monitoring on your own behavior change. So this group will just get the Fitbit, and we'll see what happens as they track their own steps, and they won't get the Twitter intervention. And then the third group, of course, will need to control and compare to a group that is ready to change their physical activity but doesn't get any intervention from us. This is a waitlist control, so they will get the treatment eventually. So this design allows for multiple comparisons at the outset, and it's about 3 months or 100 days. And then after that, we'll assess them on different things like their physical activity, their self-efficacy, their confidence, and their mindfulness. But then we go on. Second phase will be another 3 months. Maybe 3 months is enough. Maybe it's going to drop off. Maybe it will just continue to increase. So the second phase of our study will either be a modified version of the first in the group 1, or it will incorporate diet as well as physical activity. The second phase for this group, we'll see what the added benefit of a Tweet for Wellness intervention is on top of already self-monitoring their behavior. And then the third, the waitlist control, will actually compare themselves for that time period before to getting the full-bore intervention. And then what happens after we leave, which is the ultimate question of many behavior change interventions. So we will follow up at 3 months after that, and then another 6-month follow-up with the same assessments and see what changes over time. So again, this is a hybrid intervention, like Jody mentioned with the Tweet to Quit. It's capitalizing on that key component of social support, but also seated with our expert guidance. So they will get 1 tweet in the morning, and this will be some kind of prompt, which I'll tell you in the next slide. And this will prompt discussion or activity during the day. And then in the evening, we'll give them an engagement prompt of either thank you very much for your contribution to the group today, or if you didn't, we would love to hear from you tomorrow. So this is all automatic and based on the same format that Tweet to Quit was. So what are we going to be telling them on a daily basis? This is where we're going to be theory-driven. So it's based on behavior change theories. We've got 3 that we're going to alternate, 3 kind of behavior change theories, 1 every 3rd day. So every day they'll get 1 tweet. One of the types of behavior change theories we're going to use is implementation intention. So what's that? So we all have heard of goal setting, and goal setting is really important, but it's not always tied to your behaviors. We all know we have intentions that we don't always follow through on. So I'm going to be more physically active today is a really good goal, but it doesn't pan out in the literature as showing to be effective. So implementation intentions are different. It's what are you going to do, when are you going to do it, with a plan and a reminder or a trigger, like every time I see that person, I'm going to walk 10 steps, if that's your goal. And then also it accounts for potential barriers and plans to overcome them. So it's a very special kind of goal. And so this is going to prompt them to make what's called an implementation intention, or this specific kind of goal. Here's an example of what the tweet you would receive in the morning would be. Share a goal. At lunch today, what activity can you do and for how long? So the trigger is lunch. What can you do and for how long? Others, because it's only 140 characters, will involve more barrier acknowledgement. The second type of behavior change theory we'll be basing our tweets on, or our seeds, is the all-important emotional support. Again, unlike the in-person social support, this will be online, available real time, and so it's always accessible and more frequent than like a once-a-week support group visit. And so the tweets that generate the emotional support type of behavior change mechanism will be something like this. Sometimes we have frustrating or inactive days. What are some suggestions you have for combating negative feelings on these days? So people can share and talk about their suggestions for overcoming this kind of barrier. The third thing, as we all know, is a very popular intervention now, is mindfulness, and it's also very important and shown to be effective. So mindfulness, what it can do is it can increase the space between a trigger or a reminder and your habitual reaction. So we know if that space is really close, we're more likely to just do the behavior without thinking. The more space you have in between, the more time you have to make an intentional move that's different. So in this case, it will be adding space, but inspiring you to be more aware of the moment and your own thinking and presence in that moment. So the mindfulness prompts will be something like this. When walking outside today, notice the sights and sounds. What do you see and hear? Again, sort of connecting your mind to the action of physical activity, or connecting your mind to the moment to add space in between a trigger and a habitual behavior to allow for a change. So those are the things that the Twitters or the tweets are going to be based on. But of course, you can't just throw an intervention at somebody without figuring out if it may work. So we had to test these messages out. And we did these in a series of 3 so far surveys. One, we went to the Stanford Heart Fair and asked people about these messages. What do you think? We also did it in the waiting room at the cardiovascular clinic here at the hospital. And finally, we sent it out to our close friends and family. And we asked questions like, how relevant is this message to you? And they rated it. How likely would you be to respond to this message? And then how likely would you be to follow through on it? So we want to know these 3 things if we're going to be using these messages in the intervention. So what we found from this were a couple of interesting things, and we've modified based on this feedback. So one is people like goals, but they don't like over constraints. So time confining or my schedule's too erratic. So instead, we decided to take those tweets and allow people to set their own goals under more general guidelines. So for example, we used to have my step goal is by lunch today is blank, and I will walk around blank AM at blank AM to reach it, and people were stressed out. They're like, well, I work in the morning. What are you going to do? I can't follow this. So instead, we're going to be like, hey, being active in the morning can increase your energy for the day. What morning time physical activity can you fit in for tomorrow? Okay, so it gives you a guide, a constraint, but not overly constraining. Then again, with anything, you're always going to have people that disagree. So other people are like, hey, I really like this. Just tell me what to do. So to kind of allow for this kind of perspective, we're going to alternate these more specific ones with, or these more general inspiration ones with more specific settings. So instead of for the last blank minutes of each hour today when I'm at a desk sitting, I will stand up and stretch for blank minutes. People are like, oh, I like that. That's great. It's very specific. But then to allow for you to make that goal your own, we're going to be like, share a sitting break goal. And you can come up with your own. Or here's a nice example that you can use directly as your own. Also, people don't like that we were requiring friends. So accountability is really important, and so we tried to weave that into our intervention. But then on the other hand, some people are like, well, why are you assuming that I have somebody to walk with today? And then we realized, well, what about this private Twitter group? Couldn't they be the accountability mechanism? So we shifted it from finding an accountability friend for these tweets to actually the group. So instead of inviting X, who you may not be able to fill in, to walk with me, share your step goal with the group today. So that gets that accountability out there. And then the group is your now new moving partner. So what's next? Well, we'd like to do a final testing. Now that we've gotten all this feedback about these messages, we want to refine it. And we have a final version of the survey. We'd love for you to help out and give us your opinion. So we have a card here today that we'll pass out. If you can go on and kind of give your opinion of the tweets, it would really help us out. So help us out. And then the next step is enrollment for the Tweet for Wellness from the Women's Heart Clinic. So stay tuned for that once we have the messages ironed out. I want to give thanks to the team. Here's our team so far: Dr. Jen Tremmel, the Women's Health Clinic, and Jody, myself, and a special thank you to Kathleen Yang as a Health for All fellow who's done a lot of work on the message testing for this study, and she's really been a key part of this study.